Hello, everybody, and welcome back to the PSS podcast. As usual, we've got the usual suspects here, actually. Yeah, so it's me, I'm Shaun. I'm the Communications Officer here at the Partially Sight Society. Today, as usual, I'm joined, like I say, by Gary.
Hello, good morning.
Our low vision optometrist. We've got Anita.
Good morning, everybody.
The CEO, and we've got Nickie as well.
Good morning.
Our mental health and wellbeing practitioner. So, very recently, the charity went on a bit of excursion, didn't we, to London?
We did, yeah.
And a group held by Age UK. And as such, a lot of the members there that we did the talk to were suffering from age-related macular degeneration. And during this talk that we did, we received a lot of questions, didn't we, regarding this condition. So what we've decided to do is just have a quick chat today and just put the questions that we answered back to you guys as well. So if I want to start off, the first question we really got regarding this condition was the hospital system and the patient experience, in particular, people feeling abandoned when they've got no other treatment options available. So, Nickie, you used to work in a hospital setting helping people, especially in the eye department. So maybe can you go into detail about what people can expect from the hospital's experience and that drop off at the end as well?
I can weigh in a little bit, although I have to say it's been a couple of years since I worked in the hospital system and there's been probably many, many changes since then. The hospitals by nature, they're treating active conditions. If there's a treatment available that can be offered for a condition, that's what the patient will receive. If there's no longer anything there for the hospital to treat, that's when they may discharge. And I think with something like macular degeneration, often it's a monitored condition over a long period of time, but there may well come a time when actually injection treatment or anything else they might be receiving is no longer, it's not making any benefit for them. They're not gaining anything, and so they won't have that treatment anymore. I think that sense of feeling abandoned happens for quite a lot of people within the hospital system, not just in eye care, it's probably in lots of other areas as well.
I've noticed also, Nickie, that when they've moved to the virtual clinics in the macular clinics, the patient possibly wants to ask questions, but because that clinic that they've gone to is just to do the scans, and the technician that's doing the scans is not really allowed to talk about their condition as such, the patient then comes away feeling that they've not achieved anything, and also worry, is it got worse? They just want kind of an answer, even if it's just a thumbs up or a nod, but obviously that's not kind of allowed. So I certainly, when people come to see me for the eye examination and the low vision assessment, that's actually the thing that comes across quite a lot, it's a virtual clinic. And yet I do explain that the virtual clinic works really well, because that consultant on that clinic day, if they had to then see that patient, there's moving that patient into the room, moving them out, discussing what they've seen, 2 seconds looking at a scan, make a decision. Whereas actually that consultant, maybe next week, having had those scans, would sit jokingly say with a coffee and a laptop or a monitor, and they will actually sit and look through those a little bit more detail, look back at the previous ones, might even get a colleague from next door to come in and kind of, what do you think? Should we do this? Should we do that? Should we change it? So actually it's a good system, but from a patient perspective, it's not a good journey, is it?
There's a lot that goes on, isn't there, behind the scenes? And I think that's the thing. So all the patient then receives is that letter, with the kind of outcome of the virtual clinic. But you're absolutely right. When they come in, often it will be a very quick vision test, eye drops, any kind of imaging that they may need to have done. And then that's kind of it. You're right. And the sort of imaging technician isn't in a position to share what they may spot or they know, from reading notes or anything like that. They're not in a position to share that.
Yeah.
I think one of the other issues that we hear a lot is that there's a terminology that's used in the letters, or they'll use terms like inactive. What does that mean? Does it mean that, is that good? Is that bad? Because inactive is a little bit of a negative term. So it's that understanding of what does this actually mean? And I think it's really important to ask those questions.
Yeah, absolutely. And especially that point about inactive, it's a double negative, isn't
Yeah,
it?
it is.
So,
Yeah.
when you're surrounded by it and you're in like our situation, we become a bit accustomed to it, but we've got to think on the behalf of somebody that's brand new to it. And like I said, the language can be quite scary, can't it? So
yeah, we spend a lot of time kind of going, no, that's good.
That's
Inactive
good.
is good. You know, that's good. And they go, oh, really?
So one of the main points from this is it's important to be your own best self-advocate, isn't it? To receive the right care for yourself as well. So what practical steps can people take at the point of diagnosis to help themselves?
I think it's always useful if you can to take someone with you to the appointment, so that they can even keep notes. We often find that people come, bring someone to our appointments at the clinic and, we will have somebody taking notes, or because you don't always hear. You're quite anxious when you're going in for that appointment and that assessment. You don't always hear clearly what is being said or understood what is being said because you're in that level of anxiety. I think
even to the extent of hearing what you think you want to hear sometimes happens as well. So, things like these injections for AMD, he said it will bring my vision back. And that's not true, but that's what that person was hoping that might happen. Yeah. So I think with having that second person there, it's a little like helping with Chinese whispers. It's like kind of what did they say, and then saying it on. So it does help.
Sorry.
That's all right.
Sorry. And possibly sort of thinking of a list of questions that you want to ask before you go for that appointment, so that you're prepared. What do I need to know?
Yeah, I often used to say this to patients, and I think it's also sort of understanding that the doctor is there to help. Yes, we're all aware that, these consultations can go really quickly. It doesn't feel like they've got a lot of time for you, but actually they hold all the knowledge and they are happy to share that. But often people don't feel confident enough to go, I'm sorry, can you just explain that a little bit differently? But that is what they're there for. And I think it's just feeling, being your best advocate actually means, ask those questions, Don't be frightened to sort of say, could you explain that differently? What does that mean? What do you mean by that? What does that mean for me? Because actually, you're right. They may be hearing things that aren't quite what the doctor's actually saying. Their understanding may be different. So clarify. It's okay to do that. That's what the doctor's there for.
I think the other thing as well is, sometimes people have been told, there's nothing else we can do for you, that's it. But then find out what else is there you can do for yourself. There are a lot of organisations such as us, around the country, and find out where you can get that local help and support, because it is really important to help you get back on your feet and back on with your life after that diagnosis.
Yeah, definitely.
And if anybody can't find their local organisation, give us a ring and we'll see what we can do to help.
Signpost, aren't we? Yeah. So it is a bit of a breakneck, isn't it, when people finish the treatment and then that's it. There's nothing there. Because hospitals, they do treat conditions, they don't treat the people. So it's not the social care aspect that's by purpose, isn't it? That's hospitals treat medical conditions. So
I think the patient also feels that there's kind of the comfort blanket's been taken from underneath them and then kind of just left to it. They quite often, and I know this from normal practice, that we don't see patients that have been registered as sight impaired or severe sight impaired, partly because they feel that the optician can't help them. And then there's the opposite side of the coin, which is the wanting glasses because you believe that would actually make things better. So the kind of first scenario is that an eye examination or an eye test at an optician's is a health check primarily, and also a vision check as well. So it's to make sure there's nothing new that's occurring inside your eyes that you're not aware of. Also, any new techniques or any new treatments can be brought to the table, as it were, and that's why it's important to have a regular checks, even if you've not got very good vision and the hospital have said that's it. The other side of the coin is the person that wants to have glasses because it will make them better. I had a lady the other day who'd had a cataract operation, done a great job in both eyes, literally the prescription for distance. She used to have glasses from the age of 12, being short-sighted. She now no longer needed very much of a prescription. It's very, very tiny. So that tiny prescription will only make a tiny effect. So she was really upset when she got a new pair of glasses in the hope that it would make it better, when in fact it made no difference. And it's the explanation that should go along with the top part of your varifocal, for instance, has very little power, therefore it won't focus any better. We do need to make things bigger if you want to see a bit better. So just kind of that side of it as well. So yeah, encourage people to kind of still have eye tests, eye examinations at your opticians, but be aware that glasses won't always help the scenario that you have.
Yeah, of course. Yeah, and sometimes when we speak to people on the phone, we recommend people come in for a sight test with us. It's not funny in a way, but we do say, what do I need a sight test for? I'm registered blind.
Blind, yeah.
But it's still important, isn't it? Even though there's functioning vision is quite low. So what we're going to move on to now is another set of questions that we got from the London visit. It was common symptoms and patient concerns with their symptoms. So one of the questions we did receive was words seem to disappear when we try to read, and we talked about...
The majority of people that were around the table actually had either had wet AMD or dry macular degeneration. We kind of think about the macula and the fact that it's a centre part of your vision and that gets affected, but it's not always all uniform all the way across the macula. So you'll have, I call it little islands of vision and islands where it's not working. Sometimes those islands join together. And if you then are trying to use that centre part of your vision, but you're looking through the island that's not working, you may see the first few letters and then missing a couple and then reappearing. And that's because you're looking between those two little islands.
Right, that's interesting. Yeah.
So that's where we advise people to start trying to look, sideways past those islands, either left or right or above or below, or to find that sweet spot. To look, sort of to try and move the island out of the way so you can see more of the letter. That's easier said than done, because all of your life your vision works that you see something in the periphery and then you turn and look at it and you look straight. So basically what we're saying now is you might see something in the corner of your eye, instead of turning and looking at it straight on, you actually look to the side of it, or turn your head in a different direction in order to see it.
So we often get people as well that come in, and we're not being rude for just not looking right at you, but they're trying to utilise that sweet spot of it, aren't they? So
absolutely. I remember having a client in when I worked in South Africa, and she was a businesswoman and she had AMD, and she'd really mastered the trick of looking sideways at people. And when she used to be introduced to people, she used to say to him, okay, I'm not being funny, but I look at you sideways, it's because I can see you better. And she just brought it right out there on the table at the very beginning, and that kind of opened up the conversation. Why is that, and so on. So
it's a good way of being open about it, because it's like the disability side of it.
It is, absolutely, definitely. And that's a whole other podcast.
It is, absolutely. Yeah, we've had that with people with Stargardt's as well. I suppose when you're younger, you get used to the conversation and just get it out of the way quicker as well, possibly. But again, another time, possibly. So people they were asking on the day, why is my distance vision foggy or unclear?
Yeah, that's quite a hard one, quite broad. I'd need to kind of see what's happening with their eyes. The first thing you think of is possibly cataracts, because that tends to make things mistier and foggy, glary as well. It's also exhibited with things like glaucoma, where you lose the peripheral part of your vision. So to be fair, that was always a hard one to just come up with a simple answer, really.
Sure.
With them,
But cataracts in AMD is like the world's least funny
top
double
on my list of why, but there are other things that could cause that,
Sure. So this is a good one as well. It seems to be an interesting topic. Why does my vision seem to fluctuate from day to day or even from hour to hour?
Yeah, a good one again with those. Certainly dry eyes can cause fluctuation in vision, and again with the people around the table, that would have been quite prevalent from an age point of view. Also, if they're using any eye drops that are sort of medication eye drops for glaucoma, that can cause that a little bit as well. Lighting is a really, really important one. So I think with that question, and I've got to ask the question back, when does it happen? Does it happen when it's bright? Was it when you're trying to read? Does it fluctuate with the lighting? So that kind of is quite an important one as well. Yeah.
Would other medications affect that, and also other health conditions like diabetes and things like that?
Yeah, I mean, particularly diabetes or fluctuation in diabetes, that definitely, particularly if you have not had cataract surgery, so it's your lenses that are in there. If your diabetic control is not very good, then the lens that's in your eye will swell a little bit and then de-swell a little bit with the variant of your blood sugars, and therefore that is, if you like, one of the things that comes across in an eye exam. My vision goes flexible, and then I ask about the diabetic control, and so it's not an eye thing per se, it's actually a body thing, sort of diabetic control. So there are various ones. There are a few medications that cause it as well. Some of the antidepressant medications that tend to make your pupils a little bit bigger, so they're a muscle relaxant. We've got muscles in the iris of the eye, so again, that's the reason. So all of the questions kind of need another question back as to when.
I just wonder as well sometimes, because I find, just personally, I don't have that condition or other conditions, but sometimes I just feel like I get eye strain. I'm just tired. It depends on what I've been doing, and then I feel like my vision's not very good. And I wonder, for people who've got macular degeneration, there's still that part of the vision that's still trying to work all the time. That can cause quite a lot of eye strain. It's difficult. So your eyes are going to get tired.
And I think what happens as well is people are concentrating on reading so that they keep their eyes open because they're trying to concentrate. So they're not blinking as often, which will drop the vision. And it's like that double-edged sword. Absolutely, so just simply blinking, remember to blink, can help that one,
So we settled on that the AMD doesn't fluctuate. It's more of the secondary conditions and lighting. It's the external factors. So, Nickie, can the emotional well-being of somebody, say the outlook, that if they have a negative outlook, that will possibly affect how they're perceiving things, possibly?
And it is about the perception. Often it's not necessarily sort of a clinical thing that you can go, your vision is dropping because of this. It's often, when people are not in the best place, they have low mood, they're really struggling to come to terms with their sight loss, they're finding that frustration really overwhelming. It can almost be a little bit of a self-fulfilling prophecy for some people. They think, or they know they've got poor vision. That's what they experience continuously. That's the only bit that they focus on. And so that's part of the reason why here, obviously, we're very keen to look at what's residual, what's still there, what is working, and we put the emphasis on that. So often when we're working with people with sight loss, it's about just reframing, because it's really easy to get in that hole, and trying to come out of that can be difficult. But it can make it feel like your vision is worse. It's not to say it's not poor, and we want you to be happy about it, but it can make it feel like it's worse.
We often have, from my perspective, we have patients kind of talking to me about their world getting smaller, and that's not physically getting smaller. It's just that they used to be able to, the milk's run out, let's just go and get us a bottle of milk, whereas now it's an hour's planning on either ringing someone or getting your coat and things, and it's a bus journey, and
much more
so your world gets smaller. So you stop doing it, so your world actually gets small. So it's not physically, but from a mental point of view, it does.
People feel smaller.
Absolutely,
But these are all valid feelings, aren't they?
Yeah,
absolutely.
Listening, then you're not alone with that.
So I think the importance there is, do reach out and get that.
Talk about it.
So one of the next ones as well, I think we've done a podcast on this already, but we're going to brush on it really quick, because it's I don't have the actual numbers of how many people do suffer from it, but Charles Bonnet syndrome, associated with age-related macular degeneration. Facts.
I mean, 65% is estimated of people with AMD actually do have experiences of Charles Bonnet. And yes, we have done quite a long podcast on that one. So just quickly, it's basically visual hallucinations that we get because the eyes are not sending the messages back to the brain, and the brain gets a little bit bored and starts making them up. So, and they can be anything from just coloured lights through to physical things in the room as well. So, and again, around that table, I think there was a good 65% of people when we went down to London that had it.
So that was a track. Yeah.
Some people don't always sort of know that term, Charles Bonnet syndrome. So, you know, if you are seeing pictures, odd things in your vision that you think that's a bit odd, we've had rooms full of racing pigeons people have seen, spiders, men in bed with them, which one lady was not unhappy about. But you know, that's what we mean by that Charles Bonnet. It's that seeing images that aren't actually there, and as Gary said, it's your brain getting bored and making things up.
Yeah.
So there are some coping strategies that we can maybe just discuss quickly that can go with that.
Yeah, so it often happens for people where they're quiet and maybe on their own. So the thing for that would be to alter that. So either listen to the radio, but physically listen to it rather than just having it on as background. Because what you're then doing is using the ears to replace what the eyes are not sending. And quite often that helps. Maybe get up and go and make a cup of tea and sit back down again. Some of the visions that people have can be quite worrying. So again, you know, talk to someone about it, because it is, you know, it's helpful to talk it through. One of the key features of Charles Bonnet is that anything you do see is not auditory, so it doesn't have a voice. And again, it's quite useful when people come to see us where they have other members of the family, so we can discuss it, because it's not often the patient will not, or the person will not tell you about it. We usually bring it up in that conversation because it's not something you're going to tell me about seeing things. Because you think, I'll think you've lost the plot a little bit.
Yeah.
So,
I think something just to add to that is it's so important that you do mention it, in particular if you're going to stay in hospital. This happened to my dad, actually, who has dry macular degeneration, who suffers from Charles Bonnet syndrome, and he was going in for a procedure, and they put him in a bed that was opposite a white wall.
Yeah.
And obviously in hospital they don't often have many things on the walls, and he'd not mentioned, it wasn't in his notes, that he'd got Charles Bonnet. And unfortunately for my dad, the ones that he gets are quite terrifying. And he had, you know, some really awful visions, to the point where he wanted to discharge himself because he just felt so scared and uncomfortable. And it was a really unnecessary, awful experience for him. And it's a case of, if you know that that's what you experience, yes, tell family members. But if you are going to go and stay in hospital, let them know as well, so that you're not put in a position perhaps where it's going to make that worse. You know, they're aware of it. They can maybe think about that when they think about where you need to go on the ward.
Yeah, I suppose. And the other thing is there is medications, isn't it? Because some medications can also cause hallucinations. So they kind of need to understand that you have that sight loss diagnosis. And again, if it's an invisible disability, if you are going in hospital and you're poorly, you're not going to be able to advocate for yourself. So it is important to have a family member or someone to let the hospital staff know that you are visually impaired, because that's going to really affect your stay in hospital, even from simple things like where they put your water down. So, and if you are having hallucinations, as Nickie's dad did, you know, that they are aware of that, so they don't suddenly start going, oh my goodness, we need to play around with the medication or something, which can have other effects. So that kind of goes back to that advocacy again.
Yeah. So I think what we'll end on right now is the last point we had, which is quite a big one, and it's one we get quite often. Somebody asked, will I go blind from age-related macular degeneration? Will the person with AMD ever go blind?
If it's only age-related macular degeneration and there aren't any other conditions in the eye, then no, you will not go blind. Lights out, cannot see.
You can be registered blind. Well, it's severely sight impaired.
I've been in this field over 30 years and I've seen thousands and thousands of people with macular degeneration. Well, not one of them is blind. My oldest lady was 107 with dry AMD, and she still had quite a good level of residual vision. But sometimes that is not always explained. And in fact, I get really, really frustrated when I see a television program and the characters going, "Oh, I've got macular degeneration, I'm going blind." That's for me to scream at the television, because we just use that word blind without actually thinking about the consequences of that.
Yeah, it can actually cause people to go into a bit of crisis, can't it? When I've just been diagnosed.
I think just publicly as well, the word blind means for the public, if you like, is blind means that you can't see full stop.
Yeah.
And there's only around about, I think, 6 or 7% of people in the UK that are blind in that sense. The rest are registered blind, but they can still have some vision, whether that's central vision or peripheral vision, one eye vision, etc. So it's not that they're blind. And I think that's again that question, isn't it? Am I going to go blind, i.e. lights out, can't see? No, but you will have some difficulty centrally with macular degeneration.
Yeah.
So yes, that will change with time, but you won't go blind.
Right then, so on that note anyway, so I think we can probably call it a day there, because it's a massive subject, and we really do implore people, if you've got any questions or concerns from this podcast regarding age-related macular degeneration, please do get in touch. We are a national organisation. We're only based in Doncaster. We're only a small team of 7 people, but we are quite mighty for what we do. So please, if you've got anything, just get in touch with us. You can do that by phone. Our phone number is 01302 965 195. And more information can be found on our website, which is www.partsight.org.uk. Nothing else to do now, but thank everybody else for joining me. Gary,
you.
Anita, Nickie.
Welcome.
Thank you.
Thank you all for listening.
See you soon.
Bye.
Bye.